may be joining us to participate virtually in a listening capacity only. I would first like to propose a motion to adopt the minutes of the Audit Committee meeting held on December 5th, 2022.
Second.
I'll poll each member for their vote. Dr. Katz?
Yes.
Anielski?
Yes.
And I vote yes too, so the meetings are adopted. Now we'll have a presentation for the 2023 annual audit planning process by David Guzman and Grant Thornton.
Yeah, so my colleagues to the left, Grant Thornton, I'll start off by introducing you to Tammy, who will take it away.
So good morning, everybody. I'm Tammy Rudinsky. Hopefully I look familiar by now to you, except for these glasses. This is what happens when you sit in front of a computer too long.
Yeah.
So welcome to the 2023, can't believe we're back here, audit planning meeting together. I have Steve DeGuardi, who's the senior manager, who also has been on the account since inception, since we took over this client. And we've been working with David and James and the rest of the team really to get ready for the 2023 audit. I'll walk you through today our objectives, our timing, our scope, which is pretty similar to prior years. And feel free to stop us throughout if you have any questions through our presentation today. So, just gonna scroll. Okay, I don't know, it's not scrolling like pages, but that's okay.
We all have the presentation.
Perfect. So hopefully you have the presentation in front of you. So the first slide outlines our responsibilities. So similar to the past, our responsibility is to perform an audit for New York City Health and Hospitals for the year ending June 30th, 2023, as well as we have our insurance team who will do the New York City Health and Hospitals Accountable Care Organization financial statements for the year ended June 30th, 2023, as well as the health plan statutory financial statement audits, which they just presented the 2022. They'll be working on the 2023 shortly, as well as the annual statutory financial statements for the fiscal year ending December 31st, 2023 for New York City Health and Hospitals Insurance Company. We also perform a variety of other reports, such as the cost reports, for the year ending June 30th, 2023. So those are listed here, the AHCF and the RHCF. So those are similar responsibilities to the prior years. And of course, if there's any material weaknesses or significant deficiencies or in the internal control letter, we like to call it, we'll come back and present that at the end of our audit. The next slide lists the responsibilities of the committee, which is, those charged with governance. And the responsibilities are outlined here, overseeing the financial reporting process, setting a positive tone at the top, discussing any significant matters, as well as informing us of any fraud that they're aware of. The next slide is the responsibilities of management, preparing the financial statements under US GAAP, designing, implementing internal controls, communicating any significant accounting policies. We'll talk about some new accounting pronouncements for this year, informing us of any fraud, subsequent events, and at the end of the audit, coming back to us with a written representation letter. Morning. This next slide outlines our timeline, really consistent with the prior year. So we're in what we call our client continuance phase. I would say it's really the April-May timeframe where we work with management to sign the engagement letter, to do some initial meetings, coordinate timing with the client, as well as starting our planning procedures. So we like to do what we call our preliminary risk assessment in the May-June timeframe, which we identify understand with management if there's any changes in the current year and build those risks into our risk assessment, which ultimately it helps us develop our audit plan. We plan on doing that interim field work preliminary risk assessment in the beginning of the summer in the June timeframe. And the more that we can push up to interim, the easier our lives become and management's lives become at year end. So whether, we can do we'll talk about some testing areas, whether it be over grants or significant risk areas, revenues during the year, it really just makes the year end timing more efficient and just an easier process all around. So that is our goal this year, as it has been in the past. And then we come back in the September, October timeframe. We perform our final field work, most of our detailed testing, and then we present to this committee in October. Any questions? Yeah.
Actually, it's on the next slide. Go ahead.
So this is really the timeline for really the Metro Plus plan, because most of them are 12/31, so it kind of follows the 6/30 year end. So they come in the December, January timeframe. I know that you just presented one of their financial statements, and then we do the cost reports and the ACO. So I guess, did you have a question?
Is the ACO is June 30th, right? Is that?
The ACO, I believe, I'm just confirming, is that the June 30th timeframe? I believe so. Yes, June 30th. So I think that timing, they're just working out with the insurance team on your end. So that's fine.
So does that get consolidated into the main statements, or?
The Metro Plus does. The ACO is a separate, I mean, it's the same team. So we have an insurance team, Dana Wilson, who you've met before, who will come at the year end and present. And I know he just presented to the insurance group here at HHC. And they try doing as much as they can at the same time when they're doing the discrete component unit of Metro Plus in the financial statement. There's some things they can rely on and do dual testing. There's other things that they can't. So It just depends.
Okay, so the Metro Plus gets consolidated.
Yeah.
But not the ACO.
As a component unit, yes.
Okay,
correct.
that's why it's not.
Exactly. So they're working on the timing. They might have the timing since we prepared this a month ago, but unclear. So,
Thank you.
Madam Chair,
Yes.
focus.
yeah, sure.
I just have a question. I know that last year we got I'm sorry if I'm not using the proper name, like important deficiency.
Significant deficiency, material weakness. Material weakness, yes.
Material weakness.
Yes, of course.
Does that influence our timeline for this year in terms of monitoring and ensuring that we are compliant? I know that at that time we talked that if the management team needed any kind of guidance on
Mediation
what to
guidance,
expect, that you will provide them, but I don't know if that affects the timeline that you see here.
So what we do is we do an interim field work, as I was alluding to before. We're ready to do that as soon as management has their schedules prepared. So David and James and the team is working, I guess, internally. And as soon as they have those schedules, or if there's any questions, we're obviously always available. We don't like surprises. So the more dialogue we have, hopefully the better off we'll be at the end. We're waiting for those interim schedules to be prepared. So it doesn't have to be through 6/30, but if the grants revenue schedules are ready through March 31st, we can look at it then and provide some feedback so that doesn't come at year end and then we have any issues. We don't want any adjustments. We don't want any material weaknesses. We don't want any significant deficiencies. We want it to be clean and smooth. So we're just waiting for management. We haven't tested it yet because management isn't ready. I don't know, David, if you want to add anything.
Yeah, I think so. Behind the scenes, there's a lot of work going on to really prepare the schedules. We also have an engagement with KPMG that we're kind of hinges. A lot of our work hinges on that engagement in terms of how we move forward with certain components of grants revenue. So that's why we're kind of in a holding pattern until that work is complete. And they actually started the work this month, actually. Yeah, but behind the scenes, we're getting all the schedules ready.
Thank you.
Okay, I'm going to turn it over to Steve, who will take us through some areas of focus.
Great, thank you, Tammy. So I'm going to walk us through our key risk areas and really want to just highlight some of our key procedures that we perform over these areas. Starting first with the patient accounts receivables and related contractual and uncollectible allowances. This is an area where we spend a significant amount of time. It's by and large the largest part of your financial statements, receivables, and revenues from generated from patient services. And we perform a whole host of procedures, but really what we focus a lot on is historical cash collections and seeing how those collections are matching up with the revenue streams that are recognized during the year, as well as looking at those cash collections and how they've done on the prior year's accounts receivables, and then projecting that out to the current year receivables and seeing if we're on track and collectability is consistent. We're also looking at management's methodology for estimating allowances and paying particular attention to any assumptions that management is making. And a lot of those assumptions really manifest itself in terms of certain allowance type percentages. So what they'll say is you have X amount of gross revenue. Of that, we know we're only going to collect, let's for argument's sake, 50%. That 50%, that's an assumption, and that's what we do is we test that assumption, and usually it's based on historical collections as well as other factors. So we pay particular attention to those assumptions, because that's really what's driving management's estimate. The other area that we do should pay particular attention to as it relates to revenues is in the estimated settlements due to third-party payers. These are, generally speaking, long-term liabilities and receivables to Medicare, Medicaid, as well as other payers and other insurance carriers. And it's the Medicare and Medicaid; those are generated from the cost reports that are filed each year, and they generally take about anywhere from 3 to 5 years to ultimately settle out with CMS, the Centers for Medicaid and Medicare Services. And towards the end of that, there's generally some type of settlement, whether it be a payable from health and hospitals back to CMS, or vice versa. So sometimes there's a receivable, sometimes there's money that has to go out the door. So we look at those estimates and we see how reasonable they are. Again, looking at underlying assumptions, calculations. We have specialists that come in and look at that are specialized in this area. So really paying attention a lot to that estimate function. Moving on to the next slide, net pension liability expense and the OPEB liabilities. This is another very significant area of the organization's financial statements. And within here, too, is a very high level of estimation that goes on as it relates to assumptions that are utilized by really to the city's actuaries that do the ultimate calculation. But, Health and Hospitals is relying on those actuarial valuations to ultimately record the liabilities and the related expenses in the financial statements. What we do from an audit perspective is we have our own internal specialists that they're actuaries that will review those actuarial evaluations and test, again, the underlying data, underlying assumptions to ensure that the amounts that are ultimately reported within the financial statements are free of a material misstatement. We can move on to the next slide. Areas where we don't have significant changes or items, we can just kind of.
Could I ask a question on the pensions?
Oh, absolutely, yes.
If you were in reviewing, because the Health and Hospitals pension is all consolidated, right, with the city. So do you have the ability to just pull out the H&H piece and review separately? And would there ever be an instance where you'd find that the sort of actuarial assumptions maybe should be different from one population to the other, or that's not?
That question does get asked, but what we've really, I guess, what our teams have uncovered over the years is that there's really no significant impact.
Mm-hmm.
The populations between all the different components of the pension plan don't really, I guess, vary that differently in terms of how it would affect the ultimate the ultimate liability.
Mm-hmm.
So that is something that does get questioned, has been questioned before, but I think ultimately we come to the conclusion that it's looking at it as one large population versus individual populations from an assumptions perspective doesn't really, I think, change the ultimate liability or expense all that much. So it's, and everything's looked at through a lens of materiality, right?
Yeah.
So yes, there could be a difference, but if it's not going to be material to the overall pension plan, it's the overall to the organizations within the pension plan, then it kind of doesn't make sense to continue down that.
Right. Okay. Thank you.
Okay. So I do want to focus on the first area here, grant revenues. We've spoken, a little bit about the material weakness that came out of last year's audit, and David spoke to what management is doing around that. From an audit perspective, as Tammy mentioned, what we will do is once management is ready to provide us with that information, we'll review the grant schedules and we'll start testing the underlying data. So within the underlying data is going to be all the various grant expenditures that Health and Hospitals is going to ultimately report to FEMA or the granting agencies to support the grant revenues that have been received. We're going to test that underlying data to make sure it's accurate and complete, as well as review management's calculations to make sure that there's all the expenditures that are being reported for this year's grant revenues are unique to this year. They have not been utilized in prior years and things of that nature. And that's some of the areas where in prior years we've uncovered some of those results that led to the deficiency. So we're paying very particular attention to it early on. and we're planning for that in our interim timeframe. And then through June 30th, when we come back out in September, then we'll test that last 3 months if, as it becomes available.
Yeah, and I would say the key here is to make sure that the 331 data won't change as of 6/30. So meaning obviously you'll have 3 more months of data, but just with any area, whether it be a high risk area like grants or would be fixed assets or something, what we don't want to do is come in, test the schedule of March 31st, we come in at the end of the year and that schedule through March has changed. Because that's not efficient for anyone. That's just redoing work. It's not worth it. So as soon as management has the March 31st numbers locked in and they're comfortable with it, then we'll come in and audit it. So I just want to be very clear with that.
But then what happens for the last quarter?
No, so then we'll make selections from the last period. We
I
can
see.
take 75% of our selections just to throw that number out, for the first 9 months of the year, and then we'll just only have to do 25% of
I
our
see.
testing at year end.
Got it.
Yeah, and the purpose of that is twofold. One, it spreads out the workload right over a period of time, but also it helps us identify if there are any potential problems early on,
Right.
so that management has the opportunity, and we have the opportunity to work with management to make sure that gets corrected and alleviated prior to closing your June 30th financial statements. So this way, as of June 30th, the intention, I think, is to have this all resolved and flushed out, and then just be able to complete our testing.
So is this process slightly different from prior years because of the deficiency or the weakness?
So we did. So I guess I'll answer that 2 ways. We did try testing early in the past. It wasn't exactly ready or prepared, and we had a lot of back and forth. When you do have a material weakness, your sample sizes and different things do change, and you do have your scope does increase. And I think that's to one of the questions that you asked in a different type of manner. But I think that's important to note that we will have to focus and spend our time. It was always an area of focus and high risk because of the dollar amounts and everything like that. But when you have a material weakness, you have to sit back and say, okay, what else do we have to do? So our sample sizes will probably be slightly higher, and we might have some other work that we need to do to pay careful attention.
Thank you.
And then the last thing I want to touch on in this slide relates to capital assets and leases. So for this year, for fiscal year 23, the organization is adopting GASB 87, which really, to simplify, it places all of the leases that the organization has, whether historically they've been called operating leases or capital leases. In the past, a capital lease would appear on the financial statements as a balance sheet gross up. So there would be an asset and a corresponding liability. Operating leases, on the other hand, would only manifest itself in the financial statements as a operating lease expense within within the income statement. Under GASB 87, those operating leases are now going to be behaving very much like the capital leases of old. So this idea of operating versus capital is essentially going away. All of the leases that are applicable under this pronouncement will appear on the financial statements as a lease liability, and it's called a right to use asset. So it's really just putting everything up on the balance sheet. Very, very small financial income statement impact, but it's definitely a change in how the balance sheet is going to appear. There's going to be a lot higher assets.
What's driving that? What drove that change?
I think it's about transparency within the financial statement. So if you think about an operating lease from an economic perspective, there is an obligation of the organization over a long-term period. So let's say you have an operating lease for this building, for example, that when we'll just say it was a 10-year lease, there could be tens and tens of millions of dollars committed within that lease arrangement. But as an operating lease, that wouldn't show up as a liability. That would just show up year to year as an expense. So this really just makes it a little more transparent that there is a long-term liability related to this. Now, again, there's also an asset because you have the use of the building and the space. So it ends up being a wash on the balance sheet, essentially. But it does show
And the expense will still show up on the income statement?
Yeah, so each year the expense will show up in the income statement. So it'll bring the liability down each year. The asset will go down and the related expense will
And this is for equipment too?
It's
or
for essentially equipment, property, almost all leases.
It's a heavy lift, and management's already gone through that process of determining. And I mean, the hardest step is identifying all those leases out there.
Right.
So they're going through that process right now. As soon as they finalize it, which they're pretty close to it. I mean, if I'm speaking for you, we're going to start testing that during interim, because that's something also that we can get out of the way during interim.
Because we do a lot of stuff on a lease basis, I think, right? And so
Why it's such a big lift.
It's a big number. It's a big lift, a big number. Balance sheet.
what can we expect to, should we expect to see a big change in our balance sheet's going to grow dramatically,
Yeah.
I would expect.
Yeah, it's a right
Last
to use
year.
asset and liability in your balance sheet. It'll be a large number and it'll stick out like a sore thumb, but it's every organization. This is not HHC specific.
And this year is the first year.
Yeah, this is the first year you're adapting it.
Madam,
Oh,
yeah, I gave you president. The chair.
Chair.
I have a question. Most of the leases, at least from property, goes through the capital committee, which I'm the chair. And one of the discussion that we had is how do we present the leases for approval to the capital committee as well as to the board. And we have been putting certain areas, for example, the common charges and increases to the common charges, if we have to pay real estate taxes or not, and any operating costs that we need to pay, because sometimes it's included in the rent, sometimes not, and we try to standardize it. Are there any particular issues that we should be aware from the approval process at the capital committee and the board that we should try to incorporate into the format of presenting the leases?
You're saying to make it more consistent, or?
Yeah, like what kind of information based on this again?
Oh, based on the status.
Is there anything in particular that we should be looking at in the way that the leases are either structured or presented? Because that's why we try to create a format, because we were coming with leases
Right.
from, some of them are temporary, like summer months, like placing a cellular tower in one of our facilities, and others are 30 years. We just approve at 30 years. So they are very different, and all of them have different terms. And we try to kind of standardize it, and we are coming up with a format. But if there is anything in this kind of regulation that we need to pay attention on how the lease are structured or presented, we would love to hear it
Okay.
to see if
Let
we
me
can
think about
incorporate
that.
it.
Yeah, no, that's a good question. Let me think about it in terms of, let me see. Let me pull a couple of your leases and look at it as we're going through the lease schedule. And to see, I think a good conversation might be, let's look at that lease schedule and how you created it, because we haven't tested it or even seen a final schedule.
Mhm.
What information you're pulling and using for the calculation,
Right.
and then what information would be helpful that maybe even that you're struggling with from an accounting perspective of where do I get this information? How do I find it?
Right.
Because I know it's not clear. Like I know when we were talking with the accounting folks, some of the leases say, floors extra this square feet. It's not so clear cut. So let's go through it. That's a good question. We'll get back to you. And I think it's kind of maybe having a meeting in the minds here.
Even understanding the terms of
Yeah.
the proposed lease, it's good to know what would trigger us to record it.
Yeah.
That was described by our
Yeah.
colleagues, because
Yeah.
there is a benefit to recording the leases the way it is now in the financial statements in terms of the cost reports. So we might want to be cognizant when we're approving leases, if there's a certain term that we could
Mhm.
perhaps bake into the contract, it may trigger us to record it a certain way that'll give us a more economic benefit for that lease. So we'll try to call that out for you. I'll work with our colleagues here from Grant Thornton.
Yeah. We'll
And
take
also
it.
for your data collection, if we make sure that
Yeah.
it's structured a certain way, hopefully it will be easier. So I would recommend that for you to look at the some of the last leases that we approved. That's where
Okay.
we have been trying to get some formatting in terms of the information. And then,
Yeah,
So
what
to
you-
that point, it would, so for example, we have a rent due and then we pay utilities and taxes sometimes not. Would the utilities, taxes, all those other things also be incorporated into the liability, or?
I think
just
I think we have to look at let me look at the various lease agreements. And then, so if you send us, I don't know, if you
Yeah.
can send us like
Sure.
some of the newer lease agreements, we could take a look at it and then get back to you.
Why would a utility be a liability?
It shouldn't. That's what I'm thinking, right? It should only be
I
the,
think it would be stripped out of your,
Right.
but I'm wondering how your contracts are written. I have no idea, like if it just says one lease payment or you separate it out or.
but there are some common charges that we are kind of committed to. I don't know. Again, I don't know that is, but there's some that we kind of get the they contract directly with the electricity or the telecommunication. But some of them, I noticed that they are baked into kind of common charges, and we are committed for the 10, 20 years to pay those common charges. So I don't know if those will be a liability. That's why I'm saying, like, to check that information to see if there is anything that may be important.
Okay, so that's a good point. So I have that on my to-do list. Send me the information. We'll look at it. Okay. We just don't do
Okay.
this.
Yep. All right, then we can move on to the next slide. Just touch briefly on, as Tammy mentioned, along with the core audit team, we have our insurance audit team that's headed up by Dana Wilson and his team, and they audit the financial statements of Metro Plus that ultimately are presented with Health and Hospitals Corporation. And just, two of their most significant risk areas within Metro Plus audit relates to the claims payable IBNR reserves, as well as the premium revenue recognition. And, their approach hasn't changed over the years. It is a significant risk area. However, it is an area that I think is, very consistent. And their procedures really haven't changed from year to year. But just wanted to highlight here that these are the areas that they do touch on, that they spend a considerable amount of time, but there's no notable changes to the audit procedures or the risk assessment or risk profile related to these. Real briefly, as it relates to accounting estimates, I touched on the major accounting estimates within revenues, third-party liabilities, as well as the pension liabilities. We identify significant estimates as it relates to your capital, the capital assets and estimated useful lives. There will be some estimates within, probably within the lease liability as it relates to interest rates that are used. So as it relates to any estimates, we pay very particular attention to those because that's the area that takes or utilizes a lot of judgment from both management as well as us as the auditors to ensure that any risk of material misstatement is appropriately mitigated. And lastly, on the financial statements and disclosures, we review the financial statements not only for accuracy but for completeness. So we have a list of all the potential disclosures that there could be within financial statements, and we make sure that anything that is applicable to the organization and which is required to be disclosed is included within your financial statements. We could continue on. Let's move on to slide 12.
Well, before you go there,
Yes.
may I ask you?
Sure, yes.
From what I understand, with the Inflation Reduction Act, there is a lot more money going to the IRS to kind of double check that everybody's paying their fair share. And some of it, from what I have read, also have looked at the non-for-profit in terms of the regulations and all that. Is there any risk? I know that we are, a very large organization and shouldn't be, but is there anything that you are seeing the IRS in terms of auditing or following up or requirements that may be at risk to our organization?
Not specifically, but what we've worked with your tax team. So obviously we don't file tax returns in that sense, but we've had a lot of discussions. Scott Thompson, our non-profit, Dan Romano, our tax team. Anytime there was a bunch of different filings that we work together. So I think that they're the best ones to, share best practices, and I think they have had conversations. I forgot. I'm blanking on the name of the reports that they've worked with and with your team on your end in terms of identifying where there are risks and helping them file some different forms and stuff that are required more on the employee side. But not that I can think of off the top of my head.
That's from an IRS perspective. I think it is important to note, though, that as it relates to other federal funding that's been received through, the Provider Relief Fund grants, HHS and the OIG, which oversees HHS, they are already starting to perform their audits of organizations. And there were billions and billions of dollars that went out very quickly without regulation early on to organizations. And they're starting that process now of coming out and doing their audits. Usually there's, similar to the cost reports, about a 3 to 5 year time period that lags before they kind of start out. We're actually in that 3-year period because the first fund started going on in 2020. right? So it's within that kind of expected time range. So this is the time that they start coming out and starting to look at the compliance with the grant arrangements and grant agreements. So that is something that is actively happening.
Yeah, it's a good point. Yeah, sorry.
Interestingly enough, they actually
Yeah, right.
reached out already
Letter
and began the
recently?
process for H&H OIG.
We're.
Yeah. Okay, because a bunch of my clients, some of them, Steve and
There
I
was a
worked on
kickoff
together.
meeting recently
Okay.
with
Yeah.
OIG. Yeah.
Data gathering,
Mhm.
FEMA, like they've come after probably every single one of our clients have had some kind of conversation on the FEMA funds with them. So they're working through it and we're helping them with responses and stuff like that.
But you don't see in that case, that's what I was trying. I'm not talking about the employees,
Right.
because what I understand, IRS are also
Yeah.
looking at organizations
Yeah.
and corporations, and particularly non-for-profit. For
Right.
what I understand, I really don't know too much. So I'm concerned more about that coming, through the institution and asking
Right.
questions. And those type of audits, you don't see any bearing on this, or there are other reports that may be having a bearing?
I mean,
or-
my other clients, again, I'm not aware of anything that's happened specifically with health and hospitals, but I do have clients that get, questions and audits from time to time from different reporting or I call them oversight agencies. That kind of encompasses everything.
Go ahead. And are you specifically are you asking the question the IRS is sometimes looking at whether or not certain healthcare providers should be not-for-profits, whether they're not-for-profit status? Is that what you're referring to?
Well, I understand. Again, I'm trying to bring back to the bad experience that we had in academia. Academia is also non-for-profit, and there was a time that there were a lot of expenses that were put in the balance sheet that IRS came back and said, those expenses definitely are not allowable, and some of them have to return money. There was a big scandal like in the late 90s, early 2000s. And I believe that now with this Inflation Reduction Act, there is a lot of pressures on the IRS to make sure that everybody's kind of following the rules and not misusing their tax advantage. And also like certain investment that universities made that were questionable in terms if they were, particularly when they're talking about land deals and real estate and all that. So that's what I'm trying to bring that, and I don't know how much they're looking at this, and this puts any exposure on us. As you were talking about risk, that's what I'm
Unrelated business income tax, you're probably thinking of things like that from a typical non-for-profit agency. I would say here in this is my own verbiage here is I think what Steve alluded to is almost in a similar manner is the oversight agencies here. I think the bigger concern is the FEMA and the PRF funding. That's what they're going to come looking at because that's are you using are your FEMA expenses appropriate? Same type of concept in a different type of way as from your academic days.
I did want to mention as it relates to the Inflation Reduction Act, there's actually ironically a benefit as well that we're exploring relating to energy efficiency. So the team identified some language in there where we could potentially tap into a credit on certain projects that promote efficiency within our system. So we're looking at that as well, working with Grant Thornton on that too. Exploring that, and even the potential for purchasing like electronic vehicles, for example, financed through this credit as well. We're working with OFD on that. So just wanted to mention that.
Thank you.
That's great.
So I'll be brief. The last parts are pretty consistent also with last year, prior years. We have a technology team who specializes in healthcare as part of our audits. They look at your key financial systems. They don't look at everything within the organization, but those that really impact the finance part of health and hospitals. We don't do, a controls-based audit, but what they do is they understand your key systems. They identify any information technology risks, any controls that support it, and they test the design effectiveness. And then when we come back at the end of the year, if there's any identified recommendations, enhancements, insights, as well as if there's a significant deficiency or material weakness from a control finding that they identified, they'll come back and report it to the committee. The next slide, I think that we touched on in great detail. This is the lease. Sorry, it's not showing. Oh, yeah, the GASB lease standard. So I'm not going to go into this in any more detail other than saying we're working with management. As soon as it's ready, we'll start testing the impact of it. The next slide we leave in. It's more of the, I would say the effects, the lingering effects of COVID-19 and what we're seeing, our organizations face. Again, this is just the beginning of the new audit season. So hopefully, impact won't be as significant as it has been in the past. But, these are just some of the risk areas that we focus a little bit more on today than we may have in the pre-pandemic days. The biggest one here is probably the federal relief programs that we already touched on. And then as a result, the uniform guidance compliance. Okay. The next couple of slides, I would say till the end, are really your diversity, equity, inclusion. I know it's very important here at Health and Hospitals, at Grant Thornton as well. We place a key emphasis on this every day in our work, and I think it's just important to show our clients what we're doing as a firm. So that's why this slide is in here. And then this next slide is really the GASB pronouncements that are effective for this year as well as for future periods. I'm not going to talk about, future periods. The two that are effective here are the GASB 87 that we spoke about already. And in conjunction with GASB 87, there's GASB 96, which is very similar to GASB 87, except for that it focuses on the technology arrangements that you have. So I know management and their team we've already had discussions with Nicole and Joseph and James and David and everybody. So they're on top of it. They're working through it. They'll implement it together with 87. And then the other GASB that's effective for this year is GASB 98, which really is, I would say, a change of language. If you look at the slide, it used to be called the CAFR, or that's how we used to call it, I think. Yeah, the CIA, and the acronym is just changing. So there's nothing really impactful here other than it's a new title change in your annual report. So that's what that is. So, and then again, the other pronouncements are really future, and we'll work with management after we get through this year on GASB 87/96, which are the key big lifts for the finance department on implementing and the impacts of the GASBs down the road. But I know that you're thinking about those too as well, and already started that process. So with that, that's our prepared remarks. I know that we had a good dialogue throughout the conversation today. We're happy to answer any questions that were maybe not answered as part of the conversation, if anyone has.
Any other questions?
Really great questions. We'll get back to you as a follow-up on some of those open questions. I appreciate that.
Thank you very much. Yeah.
Thank you.
And moving on, we'll now have an internal audit update from.
Yes. Yes, I should introduce myself too.
Terrific.
I'm Joe O'Keefe. I started as the Chief Internal Audit Officer here back in December. This is my first audit committee, so.
Welcome.
Yeah. Joe, review your experience because it's certainly not new. None of this is new to you.
No, I came here, I was the audit director for Einstein Health System in Philadelphia for 14 years. I started out years ago working for the Office Inspector General, HHS. I worked for Aetna, various insurers, and then I was with Temple University for 9 years as their audit manager and audit director of their health system and all their health-related schools, medical, dental, all the other. And then I was with Crow Consulting as an outsourced internal audit director. I got to get that title right for several years. And then, yes, I came here from Einstein back in December.
Great.
So
A great experience for
yeah,
us. So
doing this for
welcome.
about 34 years. A little bit depressing at this point. Okay, get third thing. The first item we have is the New York City Comptroller's Office audit of controls over med-surg supplies at the nursing homes. This audit started back in 2020. The last request for update came in January. We responded back in February that all of their recommendations have been implemented, so that would now close out this audit. The next audit we have is the Department of Correctional Health audit, looking at access to mental health services within correctional health and what they do. This audit really is in the information gathering, scoping time period. We've had a couple introductory meetings for it. They're still gathering information and determining really exactly what their scope is, what they're going to be looking at. They collected a great number of documents and information and interviews with people that they've been doing over the last couple months, really last month or so. So we're really at the start of this audit. They estimate this audit will take 12 to 18 months to do.
Okay.
The next one we have, item B, is this audit's system-wide review of nurse hiring, both direct hire and agency nurses. This audit's been going on for a while. We are starting up and trying to finish it up now. It should be finished up within the next couple months. And then our next item is we're looking at the patient valuables process. We started out at Belmont. We'll be looking at several other facilities. We're looking at the handling of patient valuables, everything from cash, jewelry, clothes, whatever comes in with patients, and how that's handled at the facilities. And is it going back to the right people after if it's not collected, things like that, how that's all handled.
On this one, can you make sure you also consider unusual items?
Yes.
And we've had controversy. Someone has marijuana.
Yeah.
Does that go back to them? Someone has a knife. Does that go back to them? So I think we figured out that there might be some differences in local practices as to what happens, because I mean they're not expected, right? I mean the valuables thing is existed for all of time, right? Some of these other issues are more current issues on what is best to do.
Yes. Well, part of what we are doing is looking at updating the policy.
Right.
The policy was written back in 1993. We're looking at updating that policy. Those items would have to be things that would be taken into account, because we're just at Bellevue now, and we've already run into bikes and, like you said, other things that people had that are not normally people do not think of. And people came in with their bike or whatever. Now we're holding their bike for them, and we would return their bike to them. But just how you have to go through that whole process.
But in 93, marijuana would have been illegal. Now it's not. So So we have to make sure that the policy and the practice fits.
And we're going through all of them with how they describe items, whether it's jewelry, it's a watch, it's just a watch, it's not a Rolex watch, things like that, to just be as non-descriptive about things as they can, because they don't know what it really is when they're looking at it. But just going through all that and learning what their processes are and how they're handling it. And items like, marijuana, things like that could come up, but we haven't run into that one yet.
You will.
But we haven't really gotten into what everybody has at this point.
Pets, yeah.
Hospitals.
But we will take that into consideration when we're doing that audit.
I mean, a useful thing, it's a side benefit, but as we do it, we should also look to see how well we advise people to leave things home.
Mm-hmm.
So, for example, when I had surgery, no one said leave home your wedding ring. Which, if someone had said leave home your wedding ring, I would have just left it home. I thought about it. Well, it's not. No one's doing any surgery on my hand. Why can't I wear it? Turns out, I didn't even know this medically. There's a slight risk. People worry that your hands will become edematous.
What does that mean?
Full of fluid.
Well,
So they don't want you to wear a ring. So something that I would have, not at all worried about. But I could have easily, if someone had said, don't wear a ring, you take it off before you come.
Yeah.
So another, at least for, obviously that doesn't work as well for emergency things, but I wonder if our instructions, I don't think our instructions for surgery say things like, bring no jewelry.
Bring nothing.
Right,
Yes.
including, right. So that, because that's the most protective way to keep, for people to not lose their valuables, is to not bring them in the start.
And another issue they have is people wanting to hold on to their stuff and not wanting to give it up. And that's one thing they run in. They want to hold on their money so they can order food or whatever.
Sure.
While they're on the floor,
Phones.
things like that. And really, yes. And that's another thing we're looking at, how they're handling, how much money you let them keep, things like that, and how do you handle. they have, as they said, issues, people wanting to bring their iPad because they want their iPad or laptop or whatever while they're in the hospital.
Lockers maybe should be part. So some parts of Bellevue have lockers so that you can lock up your things. That's another sort of low-techy way to not have to deal with this issue. If a room, right, and those kind of lockers are not particularly expensive. It enables then people to
So a locker inside the room or
Right.
a locker area? No, in the room.
both. So when I did a radiologic test, they tell you to put in your stuff, and there's a lock there. And some of the rooms I noticed have a locker, although I didn't know to what extent they were using because I didn't bring anything at that time.
There are a lot of the issues they are facing is just people wanting to hold on to things.
The phone especially.
Phones and right, how they account for all the phones and everything else. Anybody else have any other questions on patient valuables? The next item, we're undertaking a risk assessment process. We're working with an outside consultant trying to develop a risk assessment process for the whole organization, which will then help us develop an audit plan for the year. It'll take a little while to get a good plan up and running. It's a large organization, taking everything into account can take a while. And we're still a small department. There's still only 3 people in internal audit. There'll be 4 people as next week. We are trying to hire additional, but we're a small department at this point.
This issue is particularly important to Sally.
Yeah.
Sally had raised this multiple times as something she wanted to see happen.
Yeah. So I was actually had some questions on that. So we haven't done a comprehensive sort of risk assessment audit plan.
Not a total one for internal audit right at this point. We're still trying to catch up with a lot of the audits that were underway. Just catching up with some standard audits like patient valuables is one we're looking at because it's been 30 years of looking at it. We're also looking at cashiering, some other audits that we're going to look at that are fairly standard audits that you would see on any standard audit plan. There's certain procedures you're always going to look at. You're always going to look at payroll items. You're always going to look at cashiering, things like that. And a number of those audits have not been done in several years. So we're started catching up with them. And once we develop the whole risk assessment process, and we are out talking to people in terms of at the different facilities and also at the central office, just what they see the risks are, any day-to-day problems they have, things they encounter, so that we can develop this good process. But it will take a little bit of time to do that. We've worked with Catherine in compliance in certain things and looking at them. And it's more trying to build out the department and then building out what capabilities we're going to have. We're trying to work more into like data analytics, things like that are going to be much more important in a large organization that has a lot of data, things like that, so that we can cover a lot more with a smaller staff.
Thank you.
Yep. The last item we have is around the auxiliary audits. These are the annual audit of all the auxiliaries. And we're basically starting that process. There's an outside audit firm that does it, the Bonadeo Group. They will run through the audits, whether it's a compilation audit review, depending on the level of income. We did go through an analysis to make sure that all the auxiliaries are getting the exact service they really need, that they're not getting a higher level of service. We have ones that are, $5,000 in revenue for the year. They really don't need a review or an audit. They're a fairly basic audit at that point, or a fairly basic informational sheet that would have to be returned. So we did go through and change a lot of the services they're getting to sort of direct that. There are big different costs between a compilation and an audit. So we sort of downsized a lot to their appropriate level of income or revenue.
Great.
Anybody have any questions? I mean, that's my review. All right.
Thank you.
Thank you.
And look forward to hearing as you develop your audit plan for next year. Thanks. Catherine.
Yes, good morning. Catherine Patsos, Chief Corporate Compliance Officer. Moving on to the first page here, we had in the reporting period of November 17, 2022 through March 13, 2023, we had no individuals or entities that were on the OIG or OMIG exclusion list. And we had no one who appeared on the National Plan and Provider Enumeration System or on the Death Master File. Moving on to the next page. On breaches, there were 98 incidents that we entered into our case management system. Of those, 38 were found to be violations of our HIPAA privacy policies and procedures, and 25 were not violations of our HIPAA privacy and security operating procedures. 35 are still under investigation. Of the 38 that were violations, 21 were determined to be breaches. Those breaches resulted from a variety of causes, including providing the incorrect after visit summary or discharge paperwork to a patient, registration errors, emailing a patient, emailing PHI to an unauthorized individual, providing the wrong medication to a patient, which was stopped before the patient had taken any of the medication. Photographs of patients, reviewing colleagues' medical records without justification, our release of information vendor disclosing medical records to the wrong recipient, and documenting or documentation being provided to the wrong patient. There were 54 incidents that were reported during our last meeting, the December meeting. Of those, 33 were still under investigation at the time of the meeting. All 33 of them have been closed. 22 were found to be violations of our operating procedures. 11 were not violations. Of those 22 incidents, 9 were determined to be breaches. Again, they resulted from registration errors, providing the wrong after visit summary. There was a documentation uploaded to the wrong patient's medical record. Again, also accessing a medical record of a colleague, hard drive missing, and again, our ROI vendor disclosing medical records to the wrong recipient. Moving on to Office for Civil Rights letters, we received 3 letters from the OCR between November 17 and March 13. On November 22nd, we received a letter regarding a complaint that the OCR received in October of 2022. It was from a patient who alleged that despite several attempts, he requested for his medical records that had not been provided. The OCR determined to resolve this matter informally by providing technical assistance, which they enclosed as material explaining the privacy rule and right to access to medical records, which we would share in our HIPAA training. The next letter was received on February 16th regarding a complaint the OCR received on November 9th from a patient who alleged that Jacoby had denied the request for an accounting of the disclosures of their medical records. The OCR again determined to resolve this matter informally by providing the same technical advice. However, we did investigate this complaint and discovered that Jacoby had sent the individual an accounting of their disclosures on November 9th, which happened to be the same day that the OCR received the complaint. And that accounting of disclosures indicated there were no disclosures of records outside the allowable disclosures for treatment, payment, and healthcare operations, and we will inform the OCR of that finding. On February 24th, we received a letter regarding a complaint that OCR received in November about a patient alleging that Woodhall had impermissibly disclosed their PHI when a physician disclosed their PHI to that physician's family members. They did request data and information regarding this particular incident, which we provided on March 20th. We did conduct an investigation of this incident and determined that there was insufficient evidence to support the complainant's allegations. Any questions?
Questions?
Okay. Moving on to the compliance reports. We received 83 compliance reports. 2 of them were red reports that were actually the same allegation that was about a workforce member using foul language with a patient. It was determined to be unsubstantiated. And there were 41 yellow and 40 green of lesser impact. Moving on to page 10, the billing and coding auditing services that KPMG has been engaged to conduct is underway. They are in the process, or they have been in the process of gathering information and conducting interviews with various people throughout the system in order to prepare the risk assessment to determine which areas of billing and coding that they will be reviewing. And this risk assessment should be completed. It's actually about to be completed right this week, I believe. And we will be recruiting a compliance coder who will work with them. It's part of their scope is to educate a person from the Office of Corporate Compliance on coding and auditing billing services.
So is this to look at kind of practices to help, the person that you're looking for is to audit billing and compliance?
Right.
Is that right? But will the KPMG's review help us to figure out like what we're doing is?
No, they're doing the risk assessment to determine which areas of billing and coding need our review based on the documentation that they have received of other audits that have been conducted both internally and through oversight agencies,
Okay.
as well as interviewing people, for example, from managed care, from HIM, from the Health Information Management Department,
Okay.
revenue cycle, compliance. So based on all that information that they're gathering, they will determine which are the most risk-prone areas of billing and coding that should be reviewed and
Right.
audited.
So once this is done, it'll be shared with finance and all of the people who.
Yeah, but yes.
Yeah, to try to improve processes.
The model here, which I think is a good use of consultants, is you get the consultant to teach the organization how to do it, and then
the
we'll
best
do it.
practices, Right.
Right, rather than our hiring someone and assuming that one or two people could figure out how to do it.
Yeah.
So we'll get PMG to tell us, this is what you should do, and then we'll take it internally and do it.
Right.
And that way we don't have to pay the consultants, but we get the advantage of their knowledge.
Yeah, because in some sense, it's like it's an auditing contract that is also a consulting contract to
Right.
help us improve
Yes.
our processes.
Right.
Okay, great,
Right.
thank you.
And the annual HIPAA risk analysis and security assessment that Coal Fire Systems conducts every year. This year, so far in 2023, they have assessed all the skilled nursing facilities, and they are currently gathering documentation and conducting interviews with acute care facilities.
And was there any finding from?
They have just released the workbooks, which identify different risks and compliance areas. So those are being reviewed currently. They haven't been finalized. They're the first of the ones that have been conducted. The first of the reviews. It's the first stage is the skilled nursing facilities, and then move on to the acutes, and then move on to the DNTCs and clinics, and so on and so forth.
Okay, so once they're done, you'll have a summary.
Yeah,
of the report.
yes.
Okay, thank you.
Moving on to the OMIG revised compliance program regulations. In December 2022, OMIG had issued a final ruling that affected the requirements of an effective compliance program. They made some major changes to the compliance program requirements, including that the contracts with certain vendors must specify that they are subject to the systems compliance program. Those would be vendors and contractors who are subject to our risk areas, reviewing all compliance policies and procedures at least annually and determine whether they're being followed and effective, evaluating the effectiveness of our compliance training, and making sure that we do routine internal and external audits, conducting annual reviews of our compliance program to determine whether the requirements have been met and whether it's effective. That would include on-site visits, interviews, record reviews, and surveys. And the results of those need to be shared with the Chief Executive Officer, the senior management, and the Compliance Committee and Board of Directors. There are also new requirements for our Systems Compliance Committee that include coordinating with the Chief Compliance Officer to ensure that the policies and procedures are current, accurate, and complete. and that the compliance training is completed, advocating for the adoption and implementation of the required modifications to the compliance program, and allocation of resources to the Chief Corporate Compliance Officer. Any questions?
Is this a big change for us? Okay.
It's a big change.
So we have to put in a lot of new processes, or is that?
Well, for example, the things that need to be reviewed annually, we have not, for example, policies and procedures have not been reviewed annually, and those can be, some of them can be
Time-consuming,
very
large,
time-consuming,
yeah.
yes. Reviewing and determining the effectiveness of our training and our compliance program and the policies is something that is going to be a little difficult, I think, because they were very vague in terms of, they didn't prescribe any particular methods of determining effectiveness, for example.
So are you working on a plan to kind of put this?
We are going to put it on our work plan. That's going to be one of the things that when the Enterprise Compliance Committee met in February, we discussed these new requirements and agreed that all of this should be included in the work plan to determine how we're going to meet the requirements.
And is there a time, like it has to be implemented this year, or?
I think the effective date would be, they're effective now, actually. It was as of end of March. And they have always had the authority to review the compliance requirements, but they have actually put into the regulations their, specifically mention their ability to audit.
Right. Okay.
Finally, just briefly, compliance HIPAA training. We did better this year in various different areas across the system. And pretty much every area we had a higher completion rate than 2021. That concludes my report.
Any other questions?
I actually have a question from the previous, I think, from Joseph.
Yes.
In your document in 6 of 8, you mentioned that you're meeting with the management and central offices and the facilities to determine like the areas of concern for future audits.
Yes.
Does that include growth and health on those discussions about the areas of concern that they may have? Or this is only the major 11 acute hospitals?
We try to get it to as many as we can. The first focus is going to be on the larger facilities and then work our way down through all the organization as much as we possible. We're trying to meet with as many people within the organization as we can. But we really have, it depends on how you're looking at the issue, but most of the issues are going to come from the bigger facilities just because materiality, things like that. But we are working our way through all the different facilities and as much as possible.
Thank you.
Yep.
Well, thank you. I will now propose a motion to convene an executive session to discuss confidential and privileged matters that may be related to threatened and potential litigation. Do you have a second?
Second.
Yes.
Oh, yes. Okay. Thank you, everyone. I think we're going to We are back in open session for the audit committee now. And is there any old business? Any new business? There being no further discussion, audit committee is adjourned. Thank you, everyone.
Thank you.
Thank you.
Your turn. Yes.
Over there.